This program was prepared by West Coast Study Club. I will explain to everybody what that club is. It is a study club based in Southern California, Orange County area. I will extend my invitation to everybody to consider joining, but this is a great time because we are starting a new season, so to speak, as of September. I'm also in charge of Global Dental Implant Academy for lots of things. It's an organization I helped form and co-director of it. So hold on. I have to keep going out because I can't add members when I'm in this screen. Hold on. Bear with me because I have to add a couple of people that just joined. And okay, we've got others joined now. Dr. Quinto, Dr. Mara. Okay, I think we've got, yeah, unfortunately, I do have to keep stopping to join people. It's just the way this was set up. I do apologize for the nuisance. So GDIA and the West Coast Study Club is kind of hosting this meeting, but basically I'm trying to share as much of this useful information in light of where we are. We are in a tough position. Most of us are members of one dental organization or another. Most of us belong to the dental societies, dental organizations, some specialist organizations, and whatnot. Unfortunately, when it comes to crunch time, I hate to say this, but they're not much use. And we've had a lot of negative sentiments about we shouldn't even pay the ADA dues. I don't know if I want to go that far, but do understand most of the organizations do represent you. They are not political groups. They do not represent you as like trade union does for laborers. But we expect that, and that's where the business is. Unfortunately, you know, because even the periodontal organization that I belong to, periodontal societies and whatnot, has not done very much. Very, very disappointing. So all the organizations on this page is what has helped me get to this point. Relied on a lot of the CDC, WHO, obviously because they are in the driver's seat. The group called IADS, International Association of Dental Specialists, which is a relatively new group. We have 130 members of specialists from all around the country, and I am part of that group, and I have certain roles in that group. That group was instrumental. We literally met for the past 7-8 weeks every single day. Every single day we did a Zoom meeting on that group, covered a lot of the grounds, lots of strategic analysis, what to do, what not to do, what you know, makes sense. So any of the products and protocols that we're trying to implement was kind of proven and tested in that group. So that's really the sheer value that I would like to share here. I also had a lot of help from Seattle Study Club, which the West Coast Study Club is a part of, and Seattle Study Club has been instrumental in providing information and whatnot. The Facebook group called Coronavirus and Dentistry, if you're not a part of it, please join, and I'll explain the benefits of that. NASP is a North American Society of Periodontists that I also belong to. It's an exclusive periodontal study club of roughly 50 periodontists, and there's about 11 sort of what we call board members, and that group has really put our heads together. The ultimate cheat sheets, if you haven't come across it, it's an excellent resource. Dr. Leslie Fang, he's an MD from Harvard. He runs that, and he also provided a lot of the information that I'm using here. Times like this, we have different ways of reacting. We can, I'm stopping to admit a couple of people. Dr. Zhang, Dr. Ramos, welcome. I do have to stop every time. Okay. And, we could just say, what the F, let's move on with this, or we could really start to panic. The best thing is to really have a stern mind and plan things ahead. There will be a lot of information, so I will be keeping this in a PDF form and on my webpage, on our study club webpage, westcoaststudyclub.com backslash uh, COVID resources, which looks kind of like this. All of this information will be uploaded. Please feel free to access it, share it with your friends and colleagues, because this information is meant to be out there to help everyone. Okay, that's that. Disclaimer, I do have to make a disclaimer because there's a lot of people on board. This is my personal opinion. If you want to base certain office business decisions based on what comes out of this material, please, use your common sense and logic. If there's any doubt, questions, consult your appropriate experts on this, such as your accountants, your legal representatives and whatnot. I just want to make sure that nobody gets into trouble for this. So then the question is, what qualifies this guy to speak in front of you? Well, besides all the different credentials, some of you may or may not know, I do have a master's in public health. I did receive a master in public health in 1992 at UCLA School of Public Health before I did my specialty. And 92, if you remember, was the year that the Clintons came to the White House. So Mrs. Clinton back then, Hillary Clinton, was trying to spearhead the first healthcare reform. That didn't do too well. Eventually, Obama did it. So when I was doing my master's thesis, my area of focus was comparison between delivery system in socialist economies and a capitalist economy of dentistry. That was my area of focus. I really loved that topic and studied that. So that's where I go back. Now, the latest news that I picked up from this morning, this is a publication that was published today. The key authors are affiliated with the Harvard Medical School, as you see here. This goes into the details of why this COVID is not the same thing as influenza. If somebody says, oh, it's just like it, I will really strangle that person to death, because it is not. We're not comparing it fairly. It's apples and oranges. They're not the same thing. Having said that, we've heard that term flattening the curve. Let's see where we are. This is a very interesting website where you can get this. My computer says my internet is unstable. Again, I do warn you that my internet is a little bit weak, so I'll try to talk slowly in case there's a little bit of lag. There is a winning, almost there, and need action category. So let's dissect this a little bit further. This is the curve we want to see. With passage of time, the cases go up, obviously, because there is a spread and pandemic. We want to hit the top, flatten, plateau, and then go down rapidly. That's what we consider to be a winning formula. I had to stop to let Connie in, okay? And that's what we want to see. And the first phase of this is the uncertainty. How far is going to go up? How many people are going to die? How far is going to spread? And then when we say flattening of the curve, this is the actual part we're talking about. It comes to a plateau. It flattens, doesn't go any higher. And then, of course, the last part is the downward trend. And not just a downward trend, it has to be a continued downward trend. And I think a couple of days ago, Dr. Fauci has indicated the key indicator, scientific indicator, is 14 days, 2 weeks. Why? That's more or less the incubation period for this particular bug. So, after 14 days, if it keeps going down, we know for certain that it is going to go down. And final point is it has to be down to the baseline, almost zero. That's what we are talking about. So when we don't see that curve, then we say this is in trouble. So let's look at some sample countries who's done well, who has not done well. This is a good group. And as you can see, you see my home country, Australia, China is in there. Look at the drastic drop and the flattening here. Iceland, Greece, Lebanon, Jordan, Luxembourg, etc. New Zealand, South Korea, Taiwan. Angela, Mary Chen, you guys should be proud of your homeland. These countries have done an extremely good job. Thailand, Vietnam, I mean, no question about it. These countries have done a terrific job in controlling this pandemic. The ones that have done okay, for instance, Italy was in trouble earlier on, but they eventually caught up. Germany has done okay. You see the similarity, the pattern of going down, but it's not as drastically rapid and it's not all the way to the bottom. So this is sort of reasonable, but not perfect. Certain other countries have done that. Spain, again, you know, we applaud them. They've done a tremendous job. They were in trouble at one time. Japan, I don't know if I trust that data because they've been a little bit deceptive early in the round. They really wanted to push the, Olympic agenda. So I'm not too sure. But these are the countries that are still in trouble. Many of these countries, the commonality is we're still on the upward swing. There is no flattening, and we are indeed in trouble. Brazil, we hear that we have massive debts. Canada, unfortunately, our neighborhood here is in trouble. Certain other countries, and then, of course, Mexico, our yet another neighbor. I have particular interest because we go down there to do a training program. This year we're slated to go down there 8 times. I've already been there 3, and then we got stuck. The way it's going, it doesn't look too good. And then, of course, United Kingdom and US fits right into that same pattern. And so is Sweden, that's been doing literally a deadly experiment that did not end very well. This is really, really troubling. They made some very, very poor decisions. I have to stop. I have to let Vaughn Chan in. Vaughn, welcome. I do have to stop every so often to let people in. Okay, so that's the unfortunate backdrop of where we are. Now I'm going to look at different states because this is where we need to figure out what are we going to do, how are we going to do this, based on what facts. Let's get the politics out of this. My comments are going to have some political innuendos and my biases. I can't help that, but we'll try to keep this as logical, business-like as possible. But we as humans can hide emotions, and there are some. These are the good states. These are the states that are model. Alaska, Hawaii, Montana, Virgin Islands, Vermont. Vermont, despite this good green pattern, these states, at least Vermont and Hawaii, have slowed down the opening of dental practices. As of this morning that I know of, they are still doing it with caution, which I personally welcome. And with that public health background, I think that is the correct thing to do. These are the states, these were accessed just a few days ago. These are the states that are not doing well, yet many of these people have opened up. Many of these people, these states have, oh, okay, I had to mute some of the microphones so we don't have any static. So New York is, of course, our main interest, and New York is doing better than earlier on. Connecticut and Jill Park, you're over there. They're not doing terribly well, although I understand you guys are opening up. Louisiana was in trouble, but they're doing much better. The states that are doing badly, not good at all, here we are. And unfortunately, California is in that box. We are still in the upward trend until 3 days ago. I don't know what, I will have some updated data, but it hasn't changed very much in the past 3 days. Arizona has opened up as of May 1st. Dentistry has opened up. Yet if you look at this, this doesn't make any scientific sense. We should not be opening up when we're in this first phase. Florida has opened up partially. That doesn't look terribly good. And you can see why the politicians and healthcare officials, when they look at this, they're saying California is not ready. So please, that's the logic and the metrics we're looking at. We have to put our emotions and politics and our biases out of this, and let's try to be as objective as possible. So here, all of these red lines represent states that are still in trouble. In other words, these states should not be opening dental offices, although at least, I don't have the full facts, but these ones are the ones that I have personally verified that the states have opened dental practices, to one degree or another. Tennessee, we'll look at that in just a minute. So this is the latest data. This is access today this morning, comparing New York and California. If anything, you should start seeing patients because the curvature has definitely gone down and there is a comforting thing. However, California is still all over the place, but it's still an upward trend. Terry Chang just joined. Okay, so I had to stop to let him in. All right. So when I superimposed the two images, California and New York is troubling. Now we know from a scientific back and little, public health background that I have, the way to control this is by what we call tracking. That's how we need to know who has the disease, who doesn't. Contact tracing is the method, the commonality of the nations who have controlled it well are the ones that have successfully implemented that. But in this country, unfortunately, there's a lot of fear, there's a lot of mistrust, there's a lot of simply dumb people who just don't comply, which unfortunately ends up with humongous sacrifice of innocent, which I'm very, very emotional about. So here we are dealing with a novel. Coronavirus is a novel. The word novel means it's new. We don't know much about it. We have some track record of similar viruses that we have some knowledge, but we don't know about this one because this one is new as of end of last year. So let's walk through the timeline. It started in December, as we know. And we had in this country a first death on February 29th. I had just personally just returned from a lecture trip in the Philippines. Uh, just joined. Dr. Lee has just joined from Arizona. So welcome. I had just returned, and then soon thereafter, we went to Mexico, and we actually had a soft tissue procedure. On the very day the first US casualty deaths happened, we actually were in Mexico treating this young lady. We're not sort of going against the, what's the identity thing. Uh, this is Terry's wife. She was actually our patient at the surgical program. So here's a fun shot of that program. So, when this disaster was starting to unfold, we were there. We were kind of unsure what was going, but we were hoping that things will slow down. Several days later, the World Health Organization said there's a shortage of PPE. We felt it because back in our practices a lot of you would have felt that because they wouldn't take orders for masks anymore. They were holding on to the stocks. They were being very careful with it, the suppliers, that is. And then of course, when we were in the program in Mexico, welcome Doug Baum, the orthodontist member, he just joined. When we were in Mexico, we were short of gloves and masks. And I said, guys, we need to get some. Where can we get? And the staff looked at me and says, we've tried our best. This is all we got. We just have to go easy. So we felt that on March the 3rd. March 11th, WHO finally declared this a worldwide pandemic. And there's still a debate as to what they write, were they on time and so forth. So let's put that aside for a second. March 11th is the same day that President Trump in the US went on live television, did the address for the whole nation, which didn't go very well because he was not forthright and kind of caused more chaos. That same day, my good friend, buddy, Arash Hakamian, we both decided to start a Facebook support page because this is what we needed. what the CDA and ADA and many organizations could not do for us, we said we need to support each other. So this Facebook page was created that same day that the national address was made. And about a week later, we put together a urgent forum. It was a live Facebook Live webinar type where we tried to answer some questions. Some of the things we talk about today, we kind of foresaw, and some of those things were discussed on that webinar back in March 18th. Sandra Duenas joined. Welcome, Sandra. So that was our beginning. Now, look, to my surprise, just last night I was scrolling through and said, wait, that's not our page, but it had exact same name. So I said, I looked into it, I said, what is going on? Somebody is an imposter. Coronavirus and with the, and symbol and dentistry is our page. Somebody made its page with exact same name. And we tried to figure out who it was, some individual in Pakistan. So my goodness, I mean, do we really have to compete with things like this? So anyway, that's another interesting happening. The very next day on the 19th, the California governor signed an executive order to effectively close most of the businesses, including dentistry. So that's where we came from. The next day, the 20th, I still went on to do this surgical procedure with Dr. Mary Chen. This is a gentleman that I saw 11 years ago and did a beautiful connective tissue graft. He was happy, I was happy. We did the high five. We were very, very happy with this nice result, except he developed an unusual lesion, root resorption, external root resorption. So we tried to see this gentleman carefully. We monitored him for a while. And in the end, like Dr. Mary Chen, myself, and the patient did the surgery together. So I was able to visit her beautiful office where I was a patient once. We sat down and we did the final surgery. That was the last surgery we did. That was also an important date because on that March 20th, the day after the governor proclaimed that we need to shut down, we truly did. And, my 20, almost 30 years of my dental practice, it was only the saddest day because I had to fire and let go of my staff, and we all mutually agreed this is only going to be a short while. We will come back stronger than ever was our feelings. So that's where we are. This is the actual proclamation, the executive order that was signed by Gavin Newsom on the 19th. Now, some of the other developments, a few days after that, we found out a British Columbia Canadian dentist actually died of COVID complications, but it was not from the dental practice. He had attended what's called the Pacific Dental Conference, PDC. I had given some lectures in that program many a times, and I think in hindsight, they made a mistake to not shut that down early. So a lot of people congregated there, and there was a cluster breakout of the disease. And this poor gentleman unfortunately lost his life. He was apparently somebody who was in practice in British Columbia area. So a sad loss from one of us happened earlier. So today, where are we at? As some of you may know, just a few days ago, Los Angeles County extended Safer at Home health order, from May 15th, and they extended that to July 1st. And what was the basis for that? That curvature that I showed you, the upward, the plateau, and downwards. Because we didn't see the downward trend, it was still going up. The healthcare experts felt that this is not the time to open up, too risky, we need to keep going. So do understand, I'm not defending that, I'm not fighting that. That's a simple scientific fact. So we need to understand. So let's go into a little more detail. What's open, what's not? California is working on a 4-phase opening strategy. Right now, gas stations, pharmacies, banks, and so forth, the essentials are open. What is not open is the restaurants, bars, nightclubs, gyms, public events, sporting events, hair salons, and hair salons and barbers, and they're having a fit, aren't they? And of course, dental practices and non-essential medical is in there somewhere. So that's where we are. So this is a 4 stages. Where are we at? We are at late stage 2 of the opening, right there. It's a little ambiguous, but my understanding is dentistry is going to be somewhere in stage 3, stage 4, because it's not a black and white, it's a spectrum of openings. So I think we will eventually start to open somewhere here for non-emergency, emergency to non-emergency, to pretty much all the procedures at that very final stage. So time-wise, given that the vector is 2 weeks of downward trend, each phase or stage will take at least 2 weeks is a common sense calculation. So even if we are ready to move along from stage 2 to 3 and then 4, so forth, you know, the simple math is 4 weeks. That's the Asian in me doing the math for you, okay? So based on that assumption, we're in this situation for another 4 weeks plus. So as of today, this is from this morning, Los Angeles County has made it clear non-emergency procedures should not be, treated. This is specific information for dentists by the Los Angeles County. This is, you can readily read that on the website. The California Department of Health, Public Health, pretty much parrots that and saying this is a little too early. When you look at this, we need to look at the fine print. We are technically, so long as we screen and test, we should be able to see patients coming into the dental facility for a non-emergency procedure. The key is testing. However, they're a little vague on the language, and they tend to put more emphasis on screening simply because testing is not widely available. I think Los Angeles County is doing much better than the rest of the country, but testing is still not considered universal or readily available. So it's more of a screening at this point. But let's look at the facts. This is as of yesterday. As of yesterday, now that you guys are experts at reading the graph, we are at stage 1. We are at the upward trend. We have not hit the plateau or flattening the curve yet. This is very disturbing. And when you look at the numbers, it's not very comforting. Huge caseload of cases. Unlike New York, our hospital capacity is not bad, but the number of deaths is quite astounding. When you break this down, this really is disturbing. This is very, very disturbing. 1/3 of deaths are Hispanics. Let me read this correctly. I don't know if it's deaths or cases. I'm sorry, it's cases. Cases. 1/3 of the cases are Latinos. So let's look at Orange County. Orange County does not have a clear pattern like Los Angeles, but you can read that it's generally upward trend, slight upward trend. It still has not flattened. So Orange County is in the same boat. This is the number of tests being done, which is encouraging. Number of tests are being increased, and cumulatively, the tests are increased. This is all positive news. I'm going to stop for a second to admit one more participant, Dr. John Cho. Dr. John Cho just joined. Welcome. So, this is the breakdown of Orange County, just like Los Angeles County. The number of deaths is not bad. The number of deaths is still relatively small compared to the rest of the nation. But again, if you break down the cumulative cases by race and ethnicity, that gray pie, the 34% happens to be Hispanic Latino. That is very, very disturbing as far as I'm concerned. And you look at the death by age, predominantly it's an older group, and that's not news. We've known that all along. So now switching here to where we fit in, the front lines, occupations. When they analyze the occupations with the highest risk to COVID, we are right there. This is a spectrum of the right of the screen is the high risk, the left of the screen is low risk, up and down the y-axis is simply a level of income. So dentists are high income earning, high risk individuals. Times like this, you say, gee, I wish I was a janitor with relatively low risk. But similarly, on this side of the graph is RDHs, nurses, and medical, medical professionals. And there are our beloved RDHs, and there are the dental assistants. So independent of the income, we are in the same boat. In fact, the way these guys have analyzed it, the assistants and hygienists a little bit further to the right than the dentists themselves. So that is actually quite disturbing. So most of us here, we have some hygienists, we have some assistants in this program. The dentists, the owner dentists, and the employers, we have an obligation to protect ourselves, but our vulnerable staff. That is our charge. So what has California Dental Association done? They give you a checklist. That's about it. But you know, the California Dental Association, and I don't mean to be cynical here, the president, the current president is a very good friend of mine, Rick Nagy, periodontist, a very, very brilliant gentleman. But you know, organizations can only do so much, and they are not in a power decision-making situation. They're pretty much a triaging. They can't even give us very helpful information. Now let's look at the other side though. This is a interim sort of a guide policy paper written by the American Dental Hygienists Association. This could be a little bit disturbing depending on who reads it. Dr. Anu just joined, thank you. Um, so basically, what CDA is saying, well, these are all the things you have to be careful of. You know, don't do this, don't do that. You know, get all this ready. You know, don't get sued. Get all the PPEs ready. Yeah, we know that. But that's pretty much all they tell you. They can't tell you when to open. They can tell you when not to open. They're just saying, be careful, listen to the authorities. That's pretty much what CDA is saying. But the ADHA, the American Dental Hygienists Association, is saying, we can't open until we are safe. And I honor that because that is you know, if I was a hygienist, I would feel exactly that. So the leadership in ADHS has done this very fair thing. For instance, they're pointing out to what you see on the right side of the screen, which is, you know, we never had to resort to the respirators, the N95s, as it's known, the respirators up until this point. But now it is a time when we have to. We have to become experts at it. We cannot return to work until the respirators are available, they're fitted correctly, they're tested, and so forth. And, you know, it's almost like a list of demands. Otherwise, we can't come back to work. And I think I've heard a group of different clinicians and dentists having emotional charges with this very issue. I say, come on, guys, cool down, cool down. There's nothing to be emotional about here. Let's use logics. People's lives are at risk. So let's do the logical and the right thing. Because this is the reality. This is what happened in China. We, you know, because of the mixed feelings of people finger pointing at China, the Chinese virus, the sentiment, which is not very welcome, but we know that Chinese healthcare workers worked heroically. They did suffer significant casualties in this war, so to speak. And in a way, we owe it to all healthcare professionals. You know, it doesn't really matter what international borders are, does it? This young man, you know, brings tears to your eyes. You know, he lost his life in the fight, and he was one of the so-called whistleblowers. He was the one that first said, this isn't normal. This is a very, you know, strong virus, and there's a lot of circumstantial questions as to what the heck is going on. The bottom line is he lost his life. He was one of our heroes. This is how I feel like. We as dental professionals are stuck in two hard places. We have smart viruses, the smart virus that outsmarts us every time, and not so smart people including administrators, the politicians, uh, the dental organization leaders and whatnot. And on the other hand, we have all these regulatory issues. Rightfully so, I mentioned the dental hygienist request that we can only go back to work if it's safe. Very fair. OSHA, CDC, you have heard of this one, FFCRA. Read this very carefully. You will have your heart will just stop beating, because this is part of the CARES Act, the new law that was passed by Congress recently. And on surface, what you see in the news is like, okay, Congress has done that to give some financial relief and help us in the times of need, be fair about taking time off. Yes, but it doesn't apply to dentistry. We are stuck in a very, very unusual place. We are, as practice owners, as business owners, very, very vulnerable about this situation. In other words, if one of our staff gets sick through COVID, we're screwed. That's pretty much the bottom line. The law does not protect us. So with that background, let's sort through, where we have to go. Shen Ling just joined, my partner, so welcome, Dr. Ling. So those of us who are not killed are effed. And I did censor this because we're all adults here. So then the fundamental question, when can and should we reopen? And I wish the government or the authority will say, hey, you guys are ready to open now. I don't think we will ever have that. Unfortunately, that is not going to be the case for many, many reasons. Political is a huge one because people try to shift blames. So I don't think we'll have a black and white answer. I think, and again, this is my personal opinion, you have to analyze it yourself and you have to put it into practice. We have to decide, unfortunately, not the CDA, not the CDC, not the ADA, not your local dental society. Nobody will decide that on our behalf, but we have to decide when it's truly safe to go back to work. That, unfortunately, is the reality. And the answer is essential services and safety has to be juggled. We are going to provide essential services. As days go by, the definition of emergency is going to have to change. And I'm not being cynical or trying to be smart here. That's the reality. How can somebody have a loose crown? 2 weeks, that's reasonable. 4 weeks, getting annoying. But 2 months, we are going to have some problems. So we're going to have to accommodate those patients. Our definition of essential services or emergency services is going to have to expand, but at what cost? We have to be doing it safely, not just for the patients, but for yourself and to protect the lives and health of our team. Take a look at this, for instance. Arizona was one of the earliest states to have opened. I watched this with great interest because May 1st, I believe they opened to non-emergency medical procedures. This is the actual executive order signed by the governor of Arizona. When you look at the fine print, it says PPE is not abundant. We know that, but you still have to be sure that you protect everybody safely, and you still have to be sure they don't go into the specifics of saying you need to test for COVID, but they might as well say that. It is a very, very tough situation. They put us as decision makers in a very, very vulnerable situation. So here's a poor dentist, the practice owner. We have to figure out the unemployment benefits because, let's face it, that's sort of a saving grace, isn't it? That at least some of us, and I've applied for unemployment benefit for the first time in my whole entire life. I've never ever thought that I would be in this situation, but I have. And, our staff are at the mercy of that. We have the mercy of some PPP, payroll protection plan. That's the extra loan / grant that was given by the SBAs through the Congress action. But there's a lot of ambiguity. Do we use it up? Do we not? When do we start? When's it going to end up? Is it truly a grant? Am I going to get forgiven? There's a lot of questions and answers on that one. How does the actual progress of the disease? What is the real and perceived risks? And are we ready? When we talk about ready, The answer is clear. We need to do the test. We're scientists and we're healthcare professionals. Without testing, we cannot go back to work. We were hoping week after week after week that testing will become available, and there were hints that it was going to happen. Um, Dr. Ru joined us. Thank you for coming and welcome. But we know today that massive testing like we saw in South Korea, Taiwan, and elsewhere is not going to happen. And let's not analyze that. There's a lot of political innuendo. Clearly, the White House is trying to use that for political gains. They want some sympathy. I think that's one aspect. The other aspect is once it is revealed that the testing is done, the numbers are not going to look very good. We are in a very, very vulnerable situation. 99% of our population is not tested. 99%. Whereas White House tests each other every day. All the staff gets tested multiple times throughout the day. Whereas our patients, ourselves, are not getting tested. What on earth and what the F is that? But that, unfortunately, is the reality. So let's not whine about it. Let's not get emotional. Let's get cool. Let's try to see how we steer through this. I'm not going to bore you with how we treat this particular disease. And I've looked at with a lot of interest and studied this, but it's mind-boggling. There is no cure. There is no medication. There are trials. There are, talks of getting the vaccine tested, but all of these are fantasy. The reality is we're in this for a long run, so the risk is real, and the risk is going to be there for a very, very long time. That, unfortunately, doctors, is the reality. So contact tracing, which is done successfully in many countries, looks like Los Angeles, California is trying very hard to do this. Certain metropolitan areas, certain governors and city officials are trying very hard to do this, but this is not going to be done at a national level. We know that, and we know the reasons why. So we hope that that will keep us. Let's just look at South Korea. I'm very proud of my country because they did this. Now, the background was SARS and MERS was a huge, suffering for the South Korean administration and the people. 2002, 2012, twice they were hit with this unfortunate disease, and because of that, they were well prepared. They did not take this lightly. They swung into action day one. They did extremely careful monitoring. Everybody was counted for. It was unbelievable. Every patient was given a number. So we know, we meaning the public health officials, knew whereabouts of all the patients. And, this is an example of what you see on your cell phone. You know the red person is a confirmed patient. That person's moving in the direction, people move away. That's how strict this was done. So then it's a balance of, personal liberty versus public health. And come on, for the sake of the public health, we need to sacrifice certain things. Are you really going to tell me if we are at war today, if today, 2020, the same thing happened as the Pearl Harbor, if the Nazis, Imperial Japan was attacking us, are you really going to go out and protest like, I don't want to go to war, I want to get a haircut, I want my liberty? Come on. America has really deteriorated, and the value system here is just very, very disappointing. Again, we are fighting stupid people and a very smart virus. Unfortunately, and these are our heroes, and we owe it to these heroes. They've given so much to fight this, and there are idiots like this out there. Suing salon and barbers are suing the government. Give me a break. So here we are. This is our situation. So we go through this emotional curvature, but let's get down to some reality of dentistry. This is an interesting paper written by Steve Harrell, well-known guy. John Molinari is another well-known guy. These guys have done a lot of research in dentistry, and this is a paper back in almost a decade ago, and they have clearly shown that aerosol is a problem. Aerosol does move around, especially with the advent of ultrasonic scalers and piezoelectric scalers. So that was brought up. Now, this is a very, very almost comical paper written in 1994 from UNC Chapel Hill, North Carolina group. Look at the research design, very comical yet very real. Every one of those red dots represent the AGA plate. They actually went to see the patient, even with some of the AGA plates on the operator and the assistant's head. So they actually went through the procedure, and the aerosols were produced, and they tried to collect. The bottom line is the aerosol goes everywhere. The bacteria were growing even on the backs. You see some of the area, you see there's one in the back of the operator. Even those AGA plates cultured significantly. So here is the real concern. This virus is a different virus. The reason why we call it novel virus is we've never handled this before. They are there, they're virulent, they're deadly, and they go everywhere. So these are the type of things we've been seeing online lately. This is not sufficient. Not sufficient. Number one, any respirator that has an outlet towards the front is not OSHA standard. So this might look cool, but look at the skin and the neck that's exposed. The buttons here are not adequate. There are pockets that you could trap and carry the virus from one room to another. So these are talked about because the reality is the splattering is everywhere. This is Donna Clauser. I think Donna came on board. Donna is a very good friend of mine, periodontist. We need more people like Donna. But here you see, here's some of the limitations. The neckline, I don't think that is thick enough. We need to really go the next level. The face shield, oh boy, I've seen a few patients lately, not very comfortable. Again, a couple of just random pictures I took. You cannot have the button undone. You need to have the neck closed. I wish the facial shield was bigger. You need to cover your knees. This is not acceptable anymore. We need to have knee coverage. So then you say, do we have to go this far? Perhaps that's not practical, but we really have to go, next year. Now, this is something I'll talk about in just a minute. This is something that I don't know how practical it is. I just put an order last night. So I will be getting this in several weeks, and I will tell you guys. I'll do a bit of testing and let you guys know. This is a way my lovely assistant Alexis and I have been seeing patients in the past few weeks several times for emergencies. We have our headgear that we normally don't use very much. We have the shield. This particular shield is large enough to put my light in there and move around. The glare is really bothersome, but we have to live with that. But again, the neck is an issue. So we're in the process of redesigning these gowns to have a little taller neck collar to cover up with perhaps some, buttons at the back that clip. As you know, many of you who's been to my office, we've been using this washable fabric for many years for a number of different reasons. One thing I like is to put my name on the jacket, and that's a pretty cool thing. But I think we're going to go to thicker fabric with a little more protection at the neck, and that's the direction at least our office is going. So all of these things, what is clear is a splatter is everywhere. And based on this, we have earlier on said universal barrier precaution is something that is important. High volume evacuation was an important aspect. And that sort of brought us to many different types of high volume evacuations that we already have on the market. And we'll analyze as to what works, what doesn't. Because with the coronavirus, we are pretty sure because the droplets are very fine and they have extreme survivability even on extreme conditions. So we are concerned that, that sort of distance might be the potential real issue. That Ariola has joined, so welcome. So, these are some of the things you can easily find them. What is disturbing is this report that came out of Wuhan, one of the hospitals. So this is real. Everything else is assumption of similar virus, but this is the real SARS COVID virus in real life. And what they have found is that they travel from one room to another. That's pretty much what they said. This is in a hospital setting, and don't, I did my research. Don't sort of picture in your mind a very third world, crappy, falling apart type of building. It's not. It's one of the most modern, well-built hospital, and through the duct system, the viruses were traveling. There's another data that comes from China. In a bus, they were able to contact trace somebody who was sitting in a bus, and from that person, the virus spread almost 5 meters, front and back. This is a call center in one of the digital complexes in Seoul, Korea. It's in an area called Kuro. Kuro is an area where a lot of digital stuff is done. And because Indians don't speak Korean, all the call centers are in Korea because we have to speak Korean. So these are service, after service people that sit down in a stacked room and they answer calls all day long. And when you look at the outbreak there, it was through the air conditioning system where virus went from one room to another, and it was the pattern of the air conditioning duct. And we also know that in Wuhan, was it Guangzhou? Yeah, there were actually cases of restaurant, spread. Just a second. I need to mute everybody so we don't hear any noise. Okay, there you go. When you look at that, it was a pretty clear pattern. It was right in the path of the airways of the air conditioner. So the reason why I'm going through all this is so that we have a strategic way, not in a nonsensical, paranoid way, but logical way to fight this and create a very safe dental environment. That's the logic. So my good friend Dr. Kamian made this through Dentalulu. Dentalulu is, by the way, a company that has been started. Great timing. I mean, this guy is, very fortunate in a way because it's a startup company. Dentalulu is a teledentistry company. And I think I will definitely jump into this one because one of the strategies we need to talk about is to minimize dental visits. Periodontists are guilty of it. We do one surgery, but we do 25 follow-ups, don't we? I think we're going to have to cut that down. In reality, we need less contact with the patients, less PPE costs and whatnot. But one way to do that is to do it through video conferencing. So with the HIPAA compliance and all, Dentalulu is one of the ways. We actually give a camera to the patient, a very inexpensive camera, and they will stick that into the mouse, and we see it and say, yeah, that's healing line. You don't have to come back for another 4 weeks. That sort of thing, which will be truly the reality. It's either that or this, social distancing in the operatory. So how long do these bugs, these viruses persist on the surface? And there's a lot of differing stories, but I think I heard 9 days. 9 days is the longest we've heard. Let's just give you a little background. See, 2005, the SARS virus was studied. It was 2002 when SARS virus emerged. In 2004, it just naturally disappeared. That's why we don't worry about SARS anymore. But the researcher had several years of research experience. And based on that, we know that this type of material, certain types of disinfectants work. We also know where they survive, where they don't survive. So that kind of data is very well known. So based on that, this is common knowledge now. We need, if you have ethanol of 70% or higher, in fact, 80% is even better. Hand wipe with, sanitizer with 80% is ideal. Sodium hypochlorite works very well. Triclosan does work, but I'm not a big fan of that. Sodium hypochlorite, bleach, diluted bleach, one problem. Sodium hypochlorite causes corrosion, is very unpleasant taste. You don't want that on the skin at certain concentrations and so on. But we know how to kill the bugs. So this is a relatively new paper just last month. But what did they do? They did a review. They did a whole bunch of review of all the papers on this topic. This is not the COVID-19 virus. They can't do that study that fast. These are all the previous families, relatives of COVID. And again, what we know, what is comforting is these numbers: 60 to 70% ethanol, 0.5% hydrogen peroxide, 0.1% bleach will kill this bug within about a minute. And again, we can't say this works exactly the same with the COVID-19, but based on these data, that's what we know. Okay, so that is a starting ground for our next topic. How do we do this? And I'm going to share these two videos. One is from Mitch Goda, who's a very good friend of mine, who is a practitioner in Memphis, Tennessee. He actually purchased P.D. Miller's practice. P.D. Miller is a very, very well-known periodontist, so he's purchased that practice, and he started to practice several weeks ago. Dr. Park is a periodontist also. He's also the owner of Megagen, and he also is owner of Mirror Network and his hospital, 11-story hospital with 500 employees. I went there and I was blown away with the size. Let's stop there for a second. I have to move my shoe. Let me see. I have to go to, let's see, desktop 2. Okay, and then I will share this. This is really worthy to watch because I think we will learn something here. Okay, so I need to click the play button. It's very hard to manipulate the mouse. Here we go.
It's a new day here at Periodontal Associates of Memphis, but as always, the health and safety of our patients and team members are our top priority. We've made many updates to the practice that will allow us to continue to provide the same high-quality care we've been providing patients in the Mid-South for over 40 years. Take a look.
I'm going to talk over this a little bit. So what you notice is we are going to check in people in a different way outside the normal waiting room. And some people call this the new digital waiting room, parking lot. And the people are brought into the area only when they are deemed ready so that we minimize the number of people in the facility. What you're seeing here is how they prepare the rooms, and I'll go into the details. What you saw that assistant doing with a fogger is to spray a fine mist of chemicals to disinfect the room. The big elephant tusk that you see is going to be a common sighting in dental offices, and notice how the patient was released to the back door. I've been wanting to do that for the longest time, kick the patient's out through the back door. Now we can do it legally. Okay, so the next one is, this one's a little bit longer, so I will try to um, fast forward. This gentleman is talking about his what the disease is like. He's actually in Daegu, which was the epicenter of where the problem was, and he is talking about the facility here is his manufacturing facility for Megagen implant system, and I've been there, and I've been to his hospital. Amazing facility where it's almost a dental school level. So he's talking about how they have come across all sorts of protocols that make sense, starting from washing hands properly, masking, gowning, pretty similar check-in procedures and whatnot. And my computer's a little slow. We're talking about using betadine to rinse the patient's mouth before we do start any procedure to reduce the viral load, and that's a lot of evidence behind that. And then the most important thing, if the video doesn't lag as much, hold on, is yeah, that's how we get this throat spray. Again, I will go into that and use that for the patients and for the staff, and create the virus-free environment using this chemical called HOCl. I will spend a lot of time talking about that, and that HOCl can be produced in office, or you can purchase pre-made solution. This number is important, 200 ppm. We make that, and again, he's talked about what data supports that concept. And here is a good example of what they're doing. You can imagine his office is kind of like a dental hospital. That's how big it is, with the number of traffic of patients and staff. So during lunchtime, during the break, beginning of the day lunch, and at the afternoon, they actually use these foggers. These are called ULV foggers, mist making machines, to spray this hydrochloric acid in all the environment, including the floors, furniture, countertops, even people. And I'll go into that. And you do that in the operatories, you do that in the waiting areas. And here's an example of how they're using it. There we go. So these are the kind of things that is already been proven in many other different parts of the world. Okay, since we had a good exposure, let me stop there, and then we can move on with our materials. Let's stop that. Okay. So, I would suggest you go in and look at those videos and study it. This is another good friend of mine, Dora. She was a student when I was a resident. She's now a pediatric dentist in, help me out, very close to me. Um, and she's made a beautiful video also. So I highly recommend Los Alamitos. People make similar videos for educational purposes and so on. What we need to do now is to get ready. Get your team together, have a frank discussion, get your team on board, because frankly, a lot of our team members are scared. So am I. There's a lot of unknowns. Is it safe? Are we doing the right thing? When can we go back? Is my salary guaranteed? There's a lot of questions that they have. So as a true leader, we need to show them some leadership. This is what we have made so far. We have our protocol that's written down. We have treatment consents. These are all things, work in progress. And I will share all of this with you so you can take it. Just, take my name off and put your name on it, of course. But the overall picture is to get the patients and the team ready. Get the patient and the team ready, safe. So Dr. Jamie Lee just joined. Okay, I just realized I was on a wrong page all the time. So here we go. There we go. I'm going to go back a little bit because I'm sorry, I misjudged. I was on the completely wrong page. So here is Dr. Dora Lee in Los Alamitos. And you will, when you dig into this data, you will have links and so forth. You can always look her up, but she has this on Facebook and elsewhere I found. And very good resource. This is what my office has created. So that the team understands what it is that we're doing in writing. And of course, since this was done in early April, we've made lots of changes and developed the protocol. So we're constantly updating. So this is what we're doing. We're getting the patients and the team ready. So again, big list of things here. And I'm going to go through this one by one. So don't worry about this. This is for your own sake. So you can review this and study this later on. There's a lot more to this. I'm going to stop for a second. And Dr. Kim has just joined. I'm going to have to mute everybody. We have to mute everybody. Hold on. Okay. And then let's move on. So this new era of checking in. This is my endodontist colleague literally across the hallway. They have a chair outside. They have signs saying, don't come in until you knock and we invite you in. So we have minimal contact, which is fair. And just do it in a polite and a very courteous and understandable way. What I try to do is up him by having a better chair in front of my office. We're looking at each other. You do need to purchase, if you haven't done so already, you need to purchase this. Remember, I purchased this way back in March, and it took me several weeks to get in. There's a lot of price gouging right now. Um, okay, hold on. Something's going on. I think we're hearing something in the background. I think I didn't turn the video off. Sorry about that. So if you haven't done that, at this point, go find something. Somebody might gouge you. Somebody might upcharge you for the. Too late. We have to go do it. You should have done it earlier. But about $90 or so is pretty fair price. I have about four of these. I'm not giving them out. There's my office, and there's our beautiful Gabby. She was I was trying to shoot her with the fogger. That's why she's all scared. We need to have this splash guard or sneeze guard, as they call it. They are rather pricey, but you need to get them and install them so that the patients feel comfortable, your staff feels comfortable, and they come in different sizes and configurations. Just make sure you have enough across all of the area. This is my consultation area. You can see the panoramic in the background. This is where we do treatment consultation with the patient. You do see that there's a sneeze guard there. This is a homemade. I made that. I purchased a plexiglass, bought some chain, and went there and hung that up like that. So there's a little space underneath so you can share the documents, push things back and forth. And our two lovely staff are sitting there pretending to be a patient and whatnot. This we're looking into several things. This one in particular is Yappy. We're trying to go into complete digital sign in, sign out, consent, so that we can get rid of all the paper, which might become an issue down the road. So we were on our way to doing it, but this is going to give us more initiative to do this. This is our waiting area as of last couple days. We've really cleaned it up. We used to have a huge table in the middle that's gone. We used to have a rack of uh, magazines. We used to have a coffee stand. All of that is gone. Good for us because we don't have to pay for the coffee anymore. Gosh, even the water station is gone. And all the magazines, I am never ever going to order these again. That's it. So all of those has to be done for the new era. Again, this is a list of all the things, a checklist that I will share with you guys. You can look at it and add, subtract to it. But we don't want this. This is crazy. This is a hysteria. This is what the COVID-19 PPE that the CDC is recommending. Preferred is to have this level, N95 or higher respirator, but we know that that's an issue. It's hard to get by, so they are accepting a regular face mask. The key thing is the isolation gown has to be impermeable. That's the key thing. It has to be strong enough with fabric. The problem, the dichotomy is this. The disposable ones are probably up to $8, $9, $10 each, the ones that are at that level. Are you really going to be able to afford that and change for each patient? There's a big question on that one. That's one of the reasons I decided, and we've done in-house washing with a washing machine all those years, so it wasn't a very difficult decision. The tough decision is we have to make new different style designs in a hurry. I have a team in Mexico that's looking into it. I have another team in Los Angeles. The ones that used to make, they don't do it anymore, so I'm trying to get my staff to work on it, so hopefully we'll get them. I've had a lot of people call me, ask me, can you spare me some? The answer is, I'm sorry, not right now. We are barely going to get some for ourselves, so when we get better, yes, I will share with other people. This is overkill, but this, again, there's plenty of information on this. And I did mention this before. This is our current mode. We do need to change it so that the neck area is protected better. You can see that with or without different types of face shields, it does afford some comfort. The key thing is it has to be knee length. This is Gabby. This is foot length for her, but it's got to be long enough. Our team, they're diligent. They wash them, fold them up, and we take them. And we actually changed a lot of protocol as to where we can wear it, where you wear it, where you take it off. In the past, let's face it, we're a little bit sloppy on that. You walk into the lunchroom and so on, but now that's a no-no. We cannot walk into certain areas with the PPE. This concept of donning and doffing, many of us are not quite familiar with this. It's a term that's used a lot in the hospital. When you do hospital rounds, we hear this all the time, donning and doffing, and the head nurse is always one shouting at you, you're not donning properly, you're not doffing properly. There are resources like this. You can go in and see the certain training videos so you have an idea. But the idea is to control. There's dirty part, contaminated part, and not, and you have to control that very well. So you need to go over that with your staff. If you're not familiar, you need to get familiar with it so that it's peeled off your body in a certain way. But in our office, this is what we're doing. This was actually yesterday. We had a young gentleman 2 days ago with a wisdom tooth, a huge swelling in the lower jaw. So I had to go in and see him. You see, after that, this is the same opportunity. I'm walking out and I'm tempted to walk into the lunchroom and say, oh, can't do that because I'm still wearing this dirty gear. So I have to walk down here, and this is a designated area. This is our lab where we go in. I duff. I don there, I duff there. I take this off in a certain way. All the helmets, screens are sprayed down and put into a certain area so it doesn't get mixed up. And then that's where you take all the gear off. This is where you put all the gear on. So this is something without training will be hard to get implemented because we're animals of habit. So we do things in a certain way and we have to do it 40 something times before it becomes a new habit. So, while we have some extra time, get your team in and practice, do dry runs. Make sure that, pretend that there's a patient, practice how we check them in, practice how we, sit the patient down without handshakes, which is something that's going to take a while to get used to. Make sure that they sit in a certain way, make sure they go out in a certain way, needs practice. We need to do that now. The mask issues. This is a red blood cell, as you see here. If that is an indication, our coronavirus is over there, tiny, tiny fraction. So, what common surgical masks will trap the red blood cells? Of course, if there's a blood splatter, you know that it really goes through the mask, it's on the surface, but the coronavirus, of course, may possibly get through the filter process, and that's why it's a problem. So we now have to know, and this is a very good resource. Again, you will have all of this. You can go in and do your own homework. What we know as the surgical masks here versus a cheap throwaway mask. And I'm sure by now everybody knows that there are 3 levels of the surgical mask, level 1, 2, and 3. Most people didn't know that, but now we all are experts at it. We should never buy 1 and 2 anymore. If you have 1 and 2 in the office, take them home, put them in your car, use it for going shopping, that sort of thing. But in the office, use the level 3 and only purchase level 3. So some of you, the budget might jump, but that's where we are. Do not buy the throwaways, cheap ones. That's not for our purpose anymore. So, and all of these are tested according to these things. Now, all the terminology. The N95 it means 95% of the particles of certain defined sizes is going to be filtered out. And because it's that efficient, it is called a respirator. It is not a mask anymore. The KN95 is a Chinese standard that is equivalent to the US FDA standards. So earlier on, this was being interchanged. And of course, what happens is different countries have different standards. So Japan has a completely different name. Korea has a different name. So these are the main producers, the main people that produce these. And there's a lot of confusion out there. And because of that confusion and a mind full of cash, people started to cheat, make imposters and counterfeits and so on. So it's a very vulnerable system. In large hospitals, this is what's happening. The true N95, the 3M N95s, can be put into this decontamination system. It's basically an oven We put that in, and at a relatively low temperature, it is able to kill the bug so you can reuse. It's a very, unusual situation, but that's what large hospitals are resorting to right now. These machines run about $8,000. It is highly unlikely that most dental offices will use this, but it is one consideration. Again, but N95, getting N95 is not easy. I was told yesterday that Henry Schein and what's the other company, Patterson, they will have the N95s available within the next 2 weeks. Of course, what's going to happen is they're going to give them out, sell them to their valued customers first. So I would say put your orders in now if you have accounts with them or any other source, but be careful because all of a sudden, every other person that you know and their brother is a mask seller and they are, they're doing that. So be very careful with that. Now, if you have valves in the front, I mentioned this before, you cannot use them. So don't even bother getting those. So the N95 type respirator that looks like this image here is very hard to get by, but be careful. There are a lot of people that are making fake ones and stuff like this. My good friend Scott Crone from New York City, he's telling somebody in. He's like saying this isn't right. So he's actually posted that on a social media site. So there are a lot of counterfeits out there. Be careful. Now, this is a reasonable approach. The people that did this, yeah, my hat's off to these heroes. Because of the shortage, there is a simple way to make a regular surgical mask act like an N95 because the seal is the problem. With the normal elastics, the seal is a problem. So what they do is they give out this free design. You simply get the template and put it on a piece of rubber and cut out to that template, and that piece of rubber can act like a basic sealer. If you are not sure about the quality of the mask, double up. But the key thing is to seal at the edges so that you don't have inadvertent openings to the side and so on. Now this, if you have not come across before, there is a 3D app called Bellis. In my office last year, we recently purchased a new CT machine that has a 3D camera attached. So we can do it with that device, but this one is easy. This one, you simply go on to your Apple, I believe Android is, you can do that, download this app, and you simply use it. It's free. And the company is utilizing this as a marketing and to help out the situation. It basically is a one click and it basically will design a framework based on your anatomy. And once you have it, if you have a printer, you export the file and you take it to the printer. I have a printer, but it's rather small, so it couldn't fit this one in. So I sent this one to Terry at Dentist, and the technical staff, they were able to print this. This is my mask on the Zenith. It's the Dentist product. So a little plug for the company because they're doing me a big favor. And it looks like if you're nice to Terry or Sam or one of these dentist staff here, and I know a lot of them are on the meeting here, send them your STL files and they will print them for you. Or if you have a buddy who has a printer or lab that can do this, whatever works, but getting the design is free. Once you do that, all you do is put some rubber bands around it and use it as a mask fitter. This is my good friend, Dr. Bolchi out of Dallas, is a periodontist there, and he's got all of his act together. He's made all of this for every one of his team members, so you can see he's ready. Now, this is another mask that I bought 400 of these recently. This is a Korean version of N95. It's actually quite nice. It claims that it can filter out, zero point 0.1 microns, as you see here. It has a kind of a nice design. You open that up, and it seals fairly well. But I would still insist you put in the mask framework, or this is yet another alternative. This is from Korea. This is a filter that comes, and each packet has about 30 of them in. And the video is a little bit long, but I'm gonna bore you to so that you see what's going on. You take a standard mask or the N95, and you can take that filter, and they actually give you a double-sided tape. I'm gonna fast forward because it's a little hard. You basically get the double-sided tape and tape that, and then you can wear the mask. There's extra filtration, so you can turn it sort of a regular mask into a high filtration N95 light masks. And that's unfortunately is the way things are being done. Now, if somebody uses something like this, a face mask like this, this is almost like a scuba diving gear, then you may not even have to wear a mask. Like I said, this is something I found only yesterday. So immediately I put an order for a couple of these. So as soon as it comes in, I will test it out. They claim that that's an N95 filter. I'm not sure, but at least the outlet is towards the top facing backwards of the head, so it's away from the source of the aerosol. Once the aerosol is controlled at the site, we might be able to get away with this. So the mask and now the face shield issue. Face shield is a must in this day and age. You need to have a face shield. And look at these two that looks like little minions. You can get those or the relatively simple configuration with the rubber band. You know, these are a little easier, less costly. The yellow cap really has a glare. I really don't like that very much. It's more secure, but inside there's refraction of the light, there's reflection of the light, so it just gives you a lot of headache. So I'm not a big fan, but these are relatively inexpensive. Two of these for 23 bucks. But notice my dates. I ordered them April 11th. They were supposed to come in June. Luckily, I got them 2 days ago. Okay, this one was delivered April 11th. It was delivered May 5th. It's 200 of them. Look at the price on it. It's reasonable, but you know, we need to stock up now. Otherwise, we won't be able to practice. This one is my favorite so far. It is slim, it's very light. It is this one is, you know, a little bit on the pricey side too, but also you can interchange the sheets. You can throw them out if they get too scratchy and so forth. So there are variations out there. All I can tell you is just go out there, purchase them, stock them up. You need them now. Buffon caps are probably going to be easier. We have a bunch of surgical caps that's tied down, but these are going to be easier. Again, these take a long time to get in, so every one of these are hard to get, hard to find. So I think we've said enough about the masks. Let's next talk about the intraoral vacuum evacuator. We got to get the aerosol out of there. So the first line, and especially for hygienists who are, there's no way we can not use aerosols. There's no way. There's no way hygienists are going to be able to do a full mouse of scaling and root planing with hand scaling. You know, they will just not last. So these variations of devices are out there. They've been around, the dry shield, the isolite or isodry. This is something relatively new I found. It's called the ivory relief. I was told by many this is a little more clumsy. These two are more reliable, and I've used both of these. They are reliable, but they are very hard to use. Patients tend to gag, they are big, so many operators use them by cutting and customizing and so on. But unfortunately, in the hygiene field, this might be a must. Some people go through the lengths of purchasing certain, off brands. These all cost roughly the rubber disposable part. You know, they're about $2 or $3 each. So you have to factor that in. And some of these big companies won't sell you them as replacement parts until you buy the whole system. So some people simply buy the first starter kit and then get these and use multiple operatories by having extra connections and so on. There's various ways of doing it. Another way is to simply use the actual high volume evacuator with your hand, and certain offices might like to do this. And this is a dense ply product on the left. And on the right, this ingenious Michael Shearer, who's the prosthodontist in California, he came up with this little printable device that he tackles onto it. If you go to his website, you'll find download. You can download that and use that STL file and print it yourself. I haven't tried it, but I think it's a pretty nifty idea. Mr. Thirsty is probably where our office will be going, because this one seems to be most reasonable price, and it's the size makes it more comfortable. So our team is in the process of deciding which one to use. So intraoral vacuum is almost a must, and so is the extraoral vacuum evacuator. And this is the industry leader in terms of the best quality out there. This one is it. You can see the price there. The study club, the specialist study club, have dealt with these people. We've spoken to them. We had webinars with them, and we've dealt them well. They will not give you any break. This is it. And in fact, you need to pay more than that, because the units need to be drop shipped from Swiss. Their headquarters is in La Mirada, California, really close to where I live, but they are out of stock. They will drop ship them from Swiss. So in fact, you have to pay extra. So this is big, but this is extremely powerful. You can wall mount them, and this is like Alan Faber, who's the guy that started our specialist group, and he's already purchased several, and he's tested them out, and it seems like a clear winner. This is examples of Jeff Canales is another periodontist in, I think it's Naples, Florida. He's installed these. This is from Mitch Godet, the guy that we saw the video. Now, what he did, he didn't bother getting the wheels. You see the wheels on the commercial brochure is the company one. You see how big it is? He basically got his partner to make, he's a carpenter, his periodontist slash carpenter. Huh, interesting. So he actually made this out of wood with casters, and that saved him some money, but also made it nice and slim. So you can have mobile units, you can have it attached to the wall. The interesting thing that Mitch told me is that this is so powerful, sometimes gauze, cotton flies into it, okay? So he said the pantyhose even flies into it. So like, what were you doing with the pantyhose? Well, he was trying to use pantyhose as a filter so it won't suck in these devices. And he says, even the pantyhose gets sucked in. So if you use this, that's a testament as to how strong it is. So in my practice, since I have 2 locations, we purchased one of these, it's still not delivered, and we purchased some other ones, which I'll show you in a minute. Another brand out there is this one, it's called Vannyman. This company is a local Southern California company. They are known for the lab industry. They are not necessarily designed for COVID type of situation. But those of you who've been in practice long enough remember that back in the 90s, we had a period of time where air abrasion was big. So there was a time when people were using air abrasion a lot, which kind of disappeared. And at that time, because of the dust issues, these came onto the market, and Vannyman is from that era. This one, as far as I was told, does not have the filtration to really get rid of the COVID level of issues. I saw a hand go up. I saw Dr. Mara. I'm gonna unmute you. You have a comment or question? Hold on. I can't unmute. Dr. Mara, you have a question? No? Okay, no question. We're gonna move on. I'm gonna mute everybody again so we don't have any. Okay, so you know, one of my friends, prosthodontist, purchased that, and I don't think he's given me enough feedback yet. But I'm not too sure this is one I am in favor of. And then the next product that I have found is this. This is from Korea. Again, why do products come out of Korea? Well, I'm going to say they're the most ingenious people. That's my bias. But the true fact is they went through SARS and MERS. So people, the general public, have this fear. So these became much more relevant in that society. And because of that, they actually had the technology and inventory, and it became just a perfect timing for the international market. So these is a company called Comex in Korea. They are in hyperdrive right now. They are manufacturing these at crazy levels. And there are many distributors of this particular product, different brands, different names, and looks like that's the going price. I didn't put it in here, but there's a gentleman by the name of JK Dental. They have the same one. So many of this, you'll see this on all sorts of advertisement. The good news is Dentist USA, who I work with very closely, which is affiliated with the GDIA, they were able to secure a distributorship with this company. And I can't tell you the price, that's not my job, but talk to the dentist people, they have a crazy price, but they will only do that for the existing customers. And it's way, way below the advertised price. So, I ordered 4, 6, I forget, significant number of these on the first batch. The second batch is coming and they are coming in July. That's the issue. It's like that for everybody. The other one, the IQ, the Swiss one, they're coming in June. There's nothing that's going to be available in May. There is one other product made in China that I did not even bother to put in here. It's relatively low cost, but it's very questionable. The key about this product and the IQ, that's the Swiss one, they do have filters, multiple levels of HEPA, HEPA filters, and they also have UVC, which kills the viruses. And I'll get to the UVC on a very different topic in just a minute. The Vandyman, is my understanding is there's something, but it doesn't equate to the same level. So that's what I know about these. Now, the room purifiers, because the options we have is to create a systemic suction, or what's called the negative pressure chamber. So suction is taken out of the room completely. Now, unless you rebuild your practice, that is impractical. And I know our friend, Dr. Miyamoto, our oral surgeon in our group, was actually doing that. And that's a considerable cost, and kudos to him for doing that. I think that's a brilliant move. But most practices is cost inhibitive. In my practice, the air circulation is horrible. So we've decided to put a room air purifier in each and every room. You know what's going to happen? You are going to just, and I've heard some discussions on the social media. Oh, this is overkill. We know it doesn't work. And, why go that far? Well, it's a matter of opinion, because if you have that sort of a mindset attitude, then you are going to be at the lower end of the food pyramid for the rest of your life with your practice. You really need to grow out of that, because what's going to happen in reality is everybody's going to be tough. Practices are going to be suffering. Patients are going to have less trust. They're going to have fear. They're going to have less money to spend. So whoever comes to the office and they check you out, we've had that in the past. They want to know if you're a caring person. They want to know your office is clean. And now that factor becomes even much more accentuated. When they see these things in the office, they're going to take pictures and they're going to do Google right there and say, oh, these guys have a 9.9 review filter versus not. So what I'm showing you this is rated 9.9 out of 10 of hundreds of different products, and it's called Medify. Again, what our group was able to do over the last several weeks is to interview these people. There's another Kowei product. This is a Korean product, very popular in Korea, but I don't know, it's actually considered number 4 according to Amazon. Anyway, there are different brands out there. This seems to be a very expensive brand, but not very well rated. You can actually get to this level. As the name implies, surgical clean air. This is a company that specializes in surgeries and hospitals and whatnot, but these are, you're talking about $6,000, $7,000 a unit. So I don't know if that's my, thing, but it's got to have a HEPA filter. If it has a UVC in it, it's better. Some of them do, some of them don't. So my research and our study club that interviewed most of the major companies basically zoomed into this company, Medify. So I purchased so far about 6 of these. We put in another order for 6 or 7 more because we are going to put them in every single room. This is the key. We negotiated this for you guys. If you put this code in, you will get 12% discount. Okay, you can do this online. You go to Medify and then put in that discount code. They will take 12% off. The large one's about 300, the small one's about 200. And take a look. This is a different brand. My wife likes that one. So that was placed in the office way before because of the dust issues. But we have one there, spot them. One there, and one there, okay? So the goal is to put them in every single operatory, hallway, waiting rooms, so that the people and our patients have assurance that if there is likelihood of any virus in the air and aerosol, that at least we have done our part to suck them out. So this IQ is the top of the line, and I've mentioned what this one is, but you can have several of these. In fact, we are installing one of these in one of the locations because our waiting room there is huge. So we're going to put that one in. This is the one that has a UVC in it. So it's supposed to be the most efficient. Now let's talk about UVC. That guy in the White House made a ridiculous claim not too long ago that you can put lights into human body cavities. Are you kidding me? Well, ultraviolet light, those of you who are new to this, are three, UVA, B, and C. C is the one that kills the viruses. Here's the issue. You see things like this and say, that's cool. Why don't we use that on all the surfaces? Why don't we sort of zap each other like, like what they do in Star Wars? And perhaps by doing so, we can decontaminate the gown, even the masks, our hands and face and so on. That is a ridiculous claim. And these products should be banned from the market. This is a fact because so much disinformation. This is what World Health Organization puts out there. Fact, UV lamps should not be used to disinfect hands or other areas of the skin. We have interviewed 3 different companies. So company representatives of these large industrial UV manufacturers came on Zoom meeting with 130 of our specialists. And they went through this and they all laugh at this. Can you zap each other? No way. You can, but you'll end up with cancer. It's simple and simple, okay? So if you have these units sitting around, you are really kidding yourself. Not only do they not work, if they were at that strength, you should be running out of that room fast because it doesn't take long. It takes seconds before these will cause mutation of your cells and cause cancer. So this is ridiculous products out there. Just don't fall for this. This is the type of thing we're talking about. In the hospitals, these are the companies that we have talked to, and I'm in the process of trying to install this. I need to just twist my arm of my partners. We can do it together. Take a look in the surgical suite way up here. Because of the distance and because of the angle, you can stare at the light and not be bothered. But the fact that it's just sitting there is meaningless. We need to circulate the air so air goes through that, so the air is forced to go through this light and aerosol and bacteria, viruses in the aerosol gets killed there. That's the whole purpose. If it doesn't do that, it is useless. So we're talking about very strong UV light, protected so it doesn't harm, but does its job. There's a lot of technology that goes behind it. And these devices are how places like Amazon sterilize your packages so that there's no viruses sitting on it. This is industrial level. These are the kind of things. This is from China. No human beings, an empty bus at the end of the day is put into this UVC chamber, so the whole bus inside and out is sterilized so the viruses get killed. If somebody walks in there, they will end up with cancer. So you do need to understand the science behind it. So these things are still plausible. For instance, this is a chamber that is used as electronics devices, but look at the price tag. This seems to be a little bit out of touch, at least for me. I don't know about you guys. It seems like a great idea. You can put laptops in there. You can put, your iPads if patients are signing on it. Great idea, but I don't know if that's a feasible thing. So we looked at this, but not many of us ended up purchasing. We are in the process of playing around with this. This is what barbers and hair salons are using. This does work. You just don't want to be too close to it. And this is going to be used to perhaps sterilize our masks, maybe our phones, our keys, that sort of thing. So we have, what have you got to lose? It's 99 bucks. So I've ordered 4 of these, and I will be giving you some feedback very soon once I have started to use them. First thing I'm going to do is put my staff's phones in there. I don't want to break my phone, so we'll test with their phones, maybe their hands or something. We'll do that. HOCL. This kinds of image is something very familiar at this point. This is actually in the subway train station in Seoul, Korea. And you have seen this on television in the past several weeks. Hypochlorous acid. This is relatively new to our vocabulary. I got to know this because of the area of a topic that I lecture on. We talk about chlorhexidine, we talk about bleach, we talk about various antimicrobial solutions, and hypochlorous acid has been in dentistry for that reason. It's a weak acid. It's a variation of bleach. Not the same thing, it's a variation. It is a very effective viricide at a certain pH and at certain ppm, parts per million. These are the products that's already out there. These are the products that use the same chemical formulary as professional cleaning devices. And who uses them? Restaurants, hotels, airlines, cruise ships, and so forth use this extensively already. It's a commonplace. If you think, is it safe for your skin and so on? Yes, restaurants use these to wash vegetables and fruits. That's how they do it on cruise ships. Can you look at this? What might be in here? You guessed it. It's hypochlorous acid that's used to wash your eyes. So it is completely safe in human cells, but it is virucidal. So these products have been around. Bring it close to home. Clusis has HOCl, hydrochlorous acid, in them. And we've been using this. Some of us didn't even realize the connection there. So that's how we have been. Now, of course, we were shadowed by some ridiculous claims. You know, I was in the public health program when they introduced this, and everybody in the public health program at that time came to ask me, because I'm the only dentist there, said, hey, now they have triclosan in toothpaste. Is that safe? And I said, that doesn't sound safe. So we were pondering, and of course, years later, it took another whole 10, 15 years before it caught up and said, this is not a good idea, and they finally banned it. So triclosan is banned, and I think it should have been banned way, way earlier. It is way toxic of a chemical for human body. But unfortunately, Procter & Gamble lobbied its way through, and they did their tremendous harm to the patients. This is the type of thing that's already out there because of the unique features. People are, I think they're upcharging a little bit. It's a little bit heavy for a simple rinse, but this is something we can use on patients now. So right now, this is a hot topic, and a lot of research is being done, and many, many people and companies and industry is jumping onto this. And I think it's going to be very, very soon before virtually everybody in dentistry is going to be using it routinely. This is what's been out there. Again, Korea, China, Asian countries have been at the forefront because of their past where they had SARS and other things. So this is, for instance, one particular product of how you make this at home using simple salt. It has to be kosher salt because you can't have iodine in it. It has to be kosher salt. It has to be tap water, unfiltered water, what's the right word? Not the, well, I'm losing the term, the water. You need to put some vinegar depending on who's doing it. And this is an example of a blog site where people, common housewives in Korea, are comparing their skills and what kills the bacteria well. And this is what we can use in dental practices today. This gentleman is Alan Farber. He's a periodontist that I work with very closely. And as you can see on the screen, this is him getting excited about getting his first shipment. He was the first to get it, and I will be getting one perhaps next week. Made in Korea. Why? They've been using this all along. You know, subway stations, bus stations, restaurants, dental offices. They've been using this for well over the past 10 years. So now that has reached the US shores. Because of the huge shortage, you can get inexpensive versions like this. And because I'm so desperate, I bought one. So here is my demonstration. I'm holding it for the first time. There's just water. This is not hypochlorous acid. You turn the damn thing on. It's so noisy and it's very irregular. The water, it's basically a water sprayer, not a fogger. ULV means ultra light volume. So it's basically supposed to create mist. And you can see my hand is being saturated with water, getting wet. So I'm saying, boy, this is not a good idea. I spent $265 for that. That's going to be my backup unless somebody wants to buy it off of me. So I tried a different brand. This one was a little more expensive, more cooler. I put it on the backpack looking like the Ghostbusters. $369. This one has a little better control of the mist, so you can possibly use that. But the amount of pressure, you can see myself shaking the plant. So if that happened to be a dental chair, computer monitor, you kind of wonder, holy, all that liquid's going to penetrate these devices and you'll have a shortage. So we have an issue. So again, $369 from Amazon. The order was placed back in April and it just arrived yesterday. So we need to get something like this, which is a high quality fogger, the true fogger, and these cost approximately $800 to $900. And I'll give you all the information if you want. You have to go to this company and order the whole kit. This company makes it, distributes that device, but they actually make the solution for you. So you put their solution, like what you see in the bottle there, you put that in the fogger and then you use it. There's another company. This company gives you the device. They sell you the fogger. They also sell you this device that you make the hypochlorous acid yourself. A medical doctor owns this company, and this device comes from Korea. This is made in Korea. Again, it's been proven, it's been used there for many, many years. The key thing is when you make it, you have to use all of these chemistry. It's like going back to chemistry class. There's no guarantee it's going to be the perfect formula. You have to test it. You have to use it, get the pH tested. You have to get the ppm tested. So it's a lot of work. So you do the, you make a decision. Do you buy it in a bottle and use it without worry, or do you make it and constantly measure the pH and so on? Several of the periodontist members of the group have already purchased this. And one guy has made 8 liters of this all day long, and he started to distribute them and put them in water bottles and give them out to his referrals. So, for those of you who are nice to me and have referred me a lot of patients, maybe I'll do that. Maybe I won't do it, my staff will do it. They'll make the solution and we'll give them out as early Christmas gifts. So that, we'll see about that. I think Jill Park from Connecticut purchased a few of these, and first I said, no, that's not the right one. But now I'm thinking, you know what? You test it, and then you let me know how it works, because you've got nothing to lose. It's really cheap, but I will give you all the information. I think Jill's on the panel here. You have to purchase the ppm and pH monitor. You have to do that so that you get the exact right formula. Otherwise, it's useless. So that's the hypochlorous acid story. Now, how do you prepare the patient? The patient, whether they're coming in just for a quick post-op or an exam or even a procedure, even if they come in just take an x-ray, we are going to clean them up so that their viral load from their mouths, at least in their breath and whatnot, is minimized. That's the least we can do. So what is the right chemical to do that? And it looks like hydrogen peroxide comes out a winner. So hydrogen peroxide works. Again, I'm going back to several articles And this is the one article that has shown that on cardboard surfaces, COVID virus can survive for up to 9 days. So these are the kind of things that get people, awake at night. So, not the COVID-19, the SARS virus, I beg your pardon. So they have shown that. So based on that data, they think same thing might happen. But again, here's the assuring: 0.1% uh, bleach or 60 to 70% ethanol will knock them out within a minute. So that's what we know. So with the hypochlorous acid and so on, again, the recommendation is when you fog the room, the hallway, the lunchroom, and you can actually fog each other. You just have to pronounce it well. I just fogged you. You fog each other, and basically, if it's a fine mist that goes over your gown and your hands even, you're not going to have any chemical harm, but give it about a minute or two, and most of the viruses will be inactivated. So here's a hydrogen peroxide study. I'm going to race through this because I think there's way too much data. This is probably the important stuff. So Dr. Peter Norland, I think some of you know him. He is a fine periodontist out in the San Diego area. And the gentleman on the right is Jorgen Slotz at USC. These guys sort of came up with some recommendations. This is recent, just a couple weeks ago. And this is a slight different concept. Rinsing with sodium hypochlorite 1 to 30 mix, 1 to 30 dilution. That's straight Clorox, not the bleach with the lemon flavor, none of that, just a straight Clorox, and diluted 30 parts. He thinks, both of these gentlemen think it's a good idea for the patient, but also for the staff, because God forbid your mask wasn't effective. So somehow you bred in the vapors. Somehow the particles were bred in through your nostril. So what do they recommend? Take that 1 in 30 dilution and swish your mouth several times throughout the day. Because, once they are landed on saliva and hopefully not in your lungs, the saliva will break them down relatively quickly anyway. But if you add some Clorox to it, it has extra effect. Now, many of you who I have worked with are very familiar with this. We do that. Now, I up it a little bit. Jorgen Slotz's method is 1 in 30. I do 1 in 20. What is my logic behind it? I want this to be concentrated because most of the time when I use it for my patients, I'm getting my patients to use it in a water pick, and I'm aiming for areas such as subgingival pockets, underneath the pontic areas, hard to reach area, because by the time they reach those areas, because of the outflow of crevicular fluid, you will definitely dilute it. That's why my logic is, if it's not a passive swish, I want it stronger. Therefore, it's 20 parts water to 1 part bleach, as opposed to Jorgen Slotz's 30 parts to 1. But that's my provocative. But the other thing that these two gentlemen has mentioned, which I find to be quite delightful and perhaps very useful, is to swab the inner part of your nose with povidone iodine 3 times a day. For you, not the patient. The patient will giggle and laugh and disappear. But because you have a chance, the front and the back, and the clinician, hygienist, everybody has the potential to breathe in. Now, unless you have a lot of nasal hair, it's not going to get trapped. Sometimes it just might go straight into your lung and airway. But if you paint the surface with betadine, the chances of the aerosol or the bacteria or virus rather, hitting betadine somehow and being deactivated before going to the lung is higher. So I think this is something that makes a lot of sense to me. And again, the point is, we don't really have full answers to everything. We just want to have enough methods and weapons against this new virus. So all of these I will be making available to my team, and my team is going to decide what is their comfort level of how to do it. Talking about the team, we haven't actually started this, so I'm going to get some volunteers of my hygienist. I think I like the hygienist to start this first, and then I'll see what happens. Somebody's going to get a very dark nose if they don't aim correctly. Clothing. This is probably one of my last topics before I wrap up. You know, it is cool to wear a scrub outside the office, in the streets and the restaurants because you look like a doctor. But let's not do that. I've always really had an issue with that. So, in this new world, I think you will be looked down if you walk around street with things like this. This guy's a hero because he is stopping these ignorant people. So he's a hero. But if somebody's in a restaurant wearing a scrub, I wouldn't feel very comfortable. I would want to get out of that restaurant right away because God knows what's on that scrub. So, with that same token, I think we've implemented a policy, and I will stick to this, is that you come to the office, wear the scrub, go to work with PPE, take the scrubs off, change into street clothes, and go home. It's the right thing for the office, it's the right thing for the family. Why walk around in your car to the supermarket, to your family, to the loved ones with possible virus or aerosol on your clothing? Doesn't make any sense to me. So shoes, even, I've always been sort of critical about why do you need booties when you're doing surgery in the mouth. But in this world, I think that might be a good idea. You either have booties or have a designated pair of shoes that you leave at the office, which will be fogged with the hypochlorous acid, and then when you go home, wear different set of shoes that you drive into the car, walk into the markets and back home and whatnot. I think that makes perfect sense. And if you're violating that, you're really not helping the cause of your team members and everybody else. So that's something that we will most likely see more and more. So again, it's about the patients and the team and what we can do. Is it overkill? Who knows? It might be an underkill with certain things. So we don't want to take a chance. We want to get everything that we got under the science, and something new might come up, something might be disproven. We will keep seeing changes, but to not act or to say this doesn't make any sense, I'm out, I'm just going to do what I used to do, which is some sentiment that you might be hearing. That is wrong, that is risky, that is irresponsible. So again, all of these lists are available for everybody to share. It will be on my website. It's not on there yet. It will be there. There are a lot of other links that I have collected over the past several weeks, things that you need to, that I feel that everybody should read. So there's some links here. Go through them. They are fairly decent. Dr. Leslie Fang is my new hero. Dr. Fang is a Harvard MD, and he's written a lot. He actually is the one that runs the ultimate cheat sheet for dentistry. He has a lot of good material on there. I think it's definitely worth the money. It's $200 or $300 subscription to get into that. So that's my recommendation. There it is. That's his ultimate cheat sheet and now he's included the COVID app on that thing. Relatively inexpensive. I would definitely recommend you do that. Okay, so there's other material. Um, this gentleman, Shandu Wadwani, is another good friend of mine. He's a prosthodontist from Seattle area. He actually goes to show you how to make your own N95 face mask. Very interesting concept. This was early on in the crisis back in, there you go, March, end of March. So, things have changed a little bit. At that time, we were desperate. So I haven't done this myself, but if you really cannot get a good stock of N95 by, let's say, another month, we may have to resort to some of these things. So these links are there. This is a very unique, interesting thing. When you go there, they give you a free PDF to print. So you can print things like this, customize it, and put them on the wall. I haven't gotten to it, but we are working on it so that these signs are everywhere in the office, so everybody, patients are instructed, and we may want to customize things for our own office use. Beauty, stick one of these. Your bathrooms are out of bounds for non-patients or people who are not related to you, so kick them out. So, these are things that you can download. Okay, exactly 2 hours, 7:01 on the dot. So, I just want to take this opportunity to do a shameless plug for my own program. Many of you we've met through practice or teaching of some sort. Uh, we are right now taking this break opportunity to do a Beyond the 3-Unit Bridge as an online module. So there is a fee to this one. Talk to the GDIA people, and the nice thing is we're about halfway through the 6 sessions. Even if you are halfway through, you can still get. I just want to admit Ellen. Oh, perfect timing because I need Ellen to advertise our program. The sessions you have missed, you have access to the video, so you can go back and watch it and review things at your own pace. I think it's a great program. I'm a little biased, but do take advantage of that. My good dear friend and co-director of GDIA, Dr. Daher, is giving a presentation. This is next week. This one is a paid. You've seen plenty of free webinars. Some of these better upscale programs have very small tuition entrance fee. I think it's worth to take a look at this one. This one's a free one. This one will be next Wednesday. I will be giving a overview on how I use CBCT and applications of CBCT in general practice, not just high fancy, surgical guide fabrication, how you use it for many things besides implants, periodontics, orthodontics, airway, and so on. I'll be going over that with the Wade group. This is the Young's Dental group. So this one's a free. I don't have the invitation. Then talk to those people, get the link, and get on board. Finally, I want to get people's attention. This is the West Coast Study Club's website. It's a great website because I made it. As you can see, one of the things is the COVID resources. It's not completed yet. When you click that, this program today and all the relevant data will be on there so you can download. Why do I do that? I'm going to force you to come to my website and take a look at our program because we have a wonderful program. We started this last year. I've been running a form of study club one way or another for the past 20 or more years. And last year, I jumped into Seattle Study Club. Why? They are the best. Seattle Study Club, and I've done Spears, I've done all sorts of different things. Seattle Study Club is hands down, they are the best structured, best support, best speakers and programs. So we started our first year with 32 members, amazing programs we really thoroughly enjoyed. We have an oral surgeon, we have a dental radiologist, we have endodontists, we have prosthodontists, we have three orthodontists, a lab technician. We are a very, very well represented group, and we've had some amazing programs. And we just finished the first year. The last 2 sessions had to be online webinars. We are starting the new program come September. So come September, we'll be opening up to new membership, and it's a yearly membership. And again, this is our website, westcoaststudyclub.com, and you go to COVID resources, and that's where you'll find the material. And this is what it looks like. It will be improved in the next few days. And this is our 2020 to 2021 program. Because of the fact that we are trapped in this weird situation and uncertainty as to whether we can actually meet face-to-face, Seattle Study Club has pretty much made an online curriculum. So these are two of the programs. We meet once a month, and some of them we're hoping by October, November, we should have regular meetings, but we just don't know that. So November meeting, for instance, is John Coyce. He will be speaking live. We will, of course, wherever we are, individual homes or in a location together, listening to John Coyce lecture and discussing things. And in January, who else but Christian Coachman, the inventor of digital smile design, DSD. So these are some examples of great programs we will be offering. 10 monthly meetings. We actually have an extra 5 sessions of Business Academy where you bring your whole team members. So we tap into how to practice better, how to become more business people. So you get about 40 or more C units and $1,800 membership. And we do offer discounts for people that don't own practices and recent graduates and so on. Once you become a member, You get access to Seattle Study Club's database, their website. They do a monthly e-magazine and case reports and that sort of thing. I'm also, during my break, working on a lot of mini lectures that I'm putting online, but I'm not giving that one away. I'm only giving that to our study club members. So you will get access to that. If you want to join, you need to talk to one of these two lovely people, Dr. Ellen O, who I have worked for many, many years, even before she went to dental school. And she's an invincible part of the study club. Dr. Paul Kang is kind of relatively new to me, but these two were classmates. So those two duo are being a very, very strong resource for our club. So please talk to them, get their numbers down, and contact them. I would love to see many of you join. You know, last year we had several people. I know David Ting from Las Vegas wanted to join, but I said, you know, in the end, like, how are you going to come from Las Vegas to monthly meetings? Well, now that it's going to be possibly some online component, some of you who are out of town might be able to join. So keep that option open, and please let me know. Okay, I am going to unmute everybody and start the question and answer.
No,
So not everybody all at once,
Good
so
morning.
that we can,
Just have to
we
do
don't
each
have
other.
Thanks, Dr. Kim.
Does anybody have a question?
That's how much.
Okay, I am going to open the chat. I have not been able to see. I'm going to start to read out, and if there's more than questions, I'll try to answer those. The first question is from Rachel Moody. Rachel from Millennium. I'm gonna mute everybody so we can hear. The first question is, do the pie charts with cases by ethnicity line up with the overall population? The answer is it does not. It is unfairly represented. I don't have the data right in front of me, but there's a higher portion of Latinos who are positive than the actual Latino population, which is the sad reality. And I don't have the raw numbers in front of me. We have a question from Dr. Ru. Dr. Ru, one of our younger members. Bellus app for iPhone, but Android, you need to buy a separate camera. I didn't hear it. No, the Bellus app is a iPhone app. You download the app, and once you download the app, you actually get to use the iPhone camera, and the camera is what turns the data into a 3D, which is really fascinating. I'm gonna, you know what I'm gonna do? I'm gonna open up the Bellus 3D mask fit. There you go. If you just Google it, you'll find it easy. And maybe if I can share the screen, how do I do that? There you go. Can you guys see the screen? My computer's kind of slow right now, but if you go into Bellus 3D, there's a video that describes how to do it. It is very simple. You know, everybody can do it. So, you know, do understand they put this on the YouTube video. Okay, for the sake of time, I'm gonna move on to the next question. Where is my question? Where did it go? Uh-oh. I need to find where my questions are. Hold on. It's not sharing. Okay, now the questions reappeared. All right. Bellus app, that was a question. Vaughn Chan from up north. Did you download the demo version? Same question. You know, yeah, you do have to download the app. You need to have app operational in your phone. Yeah, talk to Terry about whether he can print it out for you. We thought it was pretty simple, but we found out it takes very long time and it's not that easy. So I think their technical team will try to help you if you want them to help. Otherwise, send it to one of your local labs that have the printing capability, or one of your buddies who has a good printer. Go bug them. Distilled water. Thank you. That's Randy. Thank you for that. I was trying to look for that word. When you distill water, you take the minerals out, and when you don't have minerals, you can't make hydro hypochlorous acid because you need the minerals for that to form that weak acid. Uh, Joe's got a lot of technical question. Yeah, I think you're a capable guy. You may be able to do it yourself. Okay, Dr. Wu has mentioned that you can get 3 feet of rubber sheets. Yeah, if you have a lot, you may want to share with other people. That would be nice. She seems to be an expert on the rubber material here. Okay, good. I think I went through most of the question. Does anybody have any other question? Von Chen says, this was an intense hands-on course. Yes, it was. There's a lot of information. In fact, what I had done is I had, people knew I was researching this. People say, can you call me and tell me about this? So I said, you know what, please just sign into the webinar. I get way too much material and I don't want to have to keep repeating. So I hope this was helpful in clearing up some of the issues. I don't profess to have all the answers. I just want to make sure that my close friends and colleagues through different organizations, through working together, I just wanted everybody to have access to the information that I was privy to. I was very lucky to be associated with a number of high-level specialists who are doing this. And let me make a final statement. You will decide what of these array of choices you're going to implement versus not. There's going to be some financial consequences. There's going to be a logistics issue. There's going to be like, does it really work? Do I need that? There's going to be a lot of questions. What is true is this, and my team is here, but I'm not saying this just because they're here. I will tell them in front of their faces or behind their backs. You need to earn trust of your team. When earlier on, when PPP and all this unemployment benefits and things, things of that discussion came up, people actually said, what if people don't want to come back to work because their unemployment benefit is so good? Well, that's a fair question, but you really have to say, hey, if your staff is so underpaid that unemployment benefit is a better option, maybe you shouldn't have hired those people. Maybe you should be in a different business. I don't mean that in a derogative way, but I really mean that. Your team members are your huge asset. I tell my wife all the time, she beats me up because of all these comments. I say, I'm sorry, but my staff are more important sometimes than even you, because they're the ones that sustain our business. They're the ones I rely on every day. And that's my honest feeling. So, you guys really have to think about that. And so think altruistically, what can I do to my team members and my patients that I feel that I have done my best? The other flip side to that is this: God forbid, we have an outbreak from your office. I can guarantee you this: your office will be talk of town. You will be on social media, such and such office, Dr. So-and-so's office, there was an outbreak of coronavirus. You will be shut down for at least 2 weeks. Your office will go through hell in terms of social media and and publications. But at the same time, um, right now, because it's still at the beginning part of the COVID outbreak, people are gonna have sympathy. Oh, somebody got the COVID. Oh, somebody got this. Oh, I'm so sorry. When it comes from your office later on, nobody's gonna feel sympathetic for you. They're gonna go after you. I had several Zoom meetings with the local labor attorneys. They are brutal. They're going to be hungrier, and they're going to come after you and say, you did not provide safety for your team or the patient, therefore you're liable, and we are going to have, unfortunately, a lot of that. This is not to scare you, this is not to go down to that track, but this is something you do need to think. My thoughts after having spoken to a number of specialists over the past several weeks from all over the country. Most of the specialists are going out. You've seen some photographs and some examples. They're going out of the way to implement these things at that level. Patients do know who does that, who doesn't. So do not put yourself in that sort of not the most quality, not the most caring practice and be labeled as such. I did mention before, the fact that the Latino community was hit hard, that's really, that is really just very, very concerning and sad. But the reality is, the Latino community is, and I don't want to overgeneralize, there are more population, they are, lower economic, and some of the dental offices in those areas are such that they may not be able to afford things at this level. That means they're at a much higher risk of further exposure. I think we really ought to become very cognizant of that. And times like this, we need to step up and do everything as healthcare professionals to minimize this crazy outbreak. So we need to do something professional here. So that's my plea to the group. And with that, I would like to end this meeting. If there's any other questions, please email me. You guys know where I live and where my contacts are. I truly appreciate it. We know that some people are from the East Coast, so those of you really late at night, get some good sleep. Those of us in California and the West Coast, now we go to get some beer.